All right, welcome to Dental Board's reviews. This is dental implantology review number 4. Okay. All right. So make sure you, if this is your first time, make sure you subscribe. Okay. And watch the previous series. Okay. So you can catch up. All right. So question number 23. What type of bone is found in the anterior mandible? Okay, so you're supposed to know, is it type 3 bone, type 4 bone, type 2 bone, or type 1 bone? Okay, so anterior mandible has type 1 bone. Okay, all right. So you're supposed to know this. This is a given. All right, it's things you need to memorize. Question number 24. Successful osseointegration implies what? Okay. Is it A, an ultrastructural direct connect is observed between the bone and the implant? B, a functional connection exists between the bone and the implant? C, 90% of the implants must be adherent to bone? D, mineral bone must be seen to be chemically attached to the titanium. All right. So if you say B, you are correct. So remember, as we discussed in the previous series, actually review series number 3, that there is no ultrastructure connection. Okay, so that's why A is wrong. All right, there's always so the implant osseointegration means the patient can start using the implant without risk of the implant becoming loose. All right, so a functional connection. All right, so Branemark has stated that osseointegration in theory and practice is defined as the continuing structural and functional coexistence. Okay, so as long as you have this continuation of structural and functional coexistence, then it's going to be considered osseointegration of the implant, possibly in the symbiotic manner between differentiated and adequately remodeled biological tissues and strictly defined and controlled synthetic components. Okay, and this provides lasting and specific clinical function without any initial rejection mechanism, okay, or initiating rejection mechanism. So it has to be biocompatible also. So the firm anchoring of a surgical implant in dentistry or bone by the growth of bone around the implant without fibrous tissue formation. That's another consideration of osseointegration. So there has to be no fibrous tissue connection, because fibrous connective tissue formation between the bone and the implant is going to cause mobility or increase mobility of the implant. So therefore, leading to implant failure. Osseointegration, you can read about the definition or the origin, okay, derives from the Greek word of osteon, which means bone, and Latin integrare, okay, to make whole. So the term refers to the direct structural and functional connection, as we mentioned, between the living bone and the surface of the implant. Now, what is considered successful osseointegration is often described as the direct contact of bone and the implant at the light microscopic level, but not, as we mentioned in the previous series, it's not at the ultrastructural level. Okay, so at the light microscopic level, you can say, oh yes, it's, there's an intimate direct bone to implant contact. However, if you look at my ultrastructure, you see that there's some spaces between the implant. But light microscopic level, okay, there's direct contact of bone and the implant. Okay, there's no conclusive evidence of any molecular bond between the metal oxide of titanium and the adjacent bone. Okay, and usually successful osseointegration will show mineralized bone in opposition to the implant. All right, So the bone right next to the implant is going to be mineralized, okay, and is usually approximately 2 microns away from the metal, okay. So ultrastructurally, there's a space between the bone and the implant, okay. However, at the light microscopic level, there's no space, all right. So intervening between the metal and the mineralized bone interface is biological layer of oxides and proteoglycans, which you're supposed to know. Okay, and in the series number 3 review, we reviewed the layers. Okay, the layers of bone or tissue surrounding the implant. All right, question number 25. What is the minimum time required for osteointegration? So you put in an implant. Okay, you ask the patient to come back. If you're going to do 2 stages, okay, how long is it going to take, okay, before you put a crown on? So the minimum time, is it A, 1 to 2 months, B, 2 to 3 weeks, C, 2 to 3 months, or D, 3 to 6 weeks? Okay, so if you said C, you're correct. So the minimum time required for cell integration is 2 to 3 weeks, 3 months. Okay. Question number 26. What layer forms on the surface of implant, making the implant more biocompatible? All right. So these are some layers. Is it a titanium dioxide and calcium phosphate, or B, calcium phosphate and hydroxyapatite, or C, titanium chloride and hydroxide, or D, sodium fluoride and titanium phosphate? Okay, so if you said C, you're correct. All right. And the question 27, okay, which of the following, so the following implants are type of implants used in modern implant dentistry? Subperiosteal implants, although not frequently but still used. Subperiosteal implants, transosteal implants, endosseous frame or endosseous-root implants. Okay, so these are the common types now. Root form. Okay, these are the ones we use now currently. Mostly used. It doesn't mean that the others are not used. The other ones are also used. But what is the greatest disadvantage of subperiosteal implants? Okay. So the greatest advantage is that they have a poor 10-year survival rate. Okay. So A is the answer. So make sure you know the disadvantage of subperiosteal implants. Okay. All right. Question 28. What is the minimum distance an implant can be placed from the inferior alveolar nerve? All right. Is it A, 1 millimeter, B, 5 millimeter, C, 2 millimeter, D, 3 millimeters? So you're supposed to know how far away from the vital structures, vital anatomical structures, that you're supposed to stay when you're placing implants. Okay. So the inferior alveolar nerve is supposed to be 2 millimeters away. Okay. So our answer is C. Okay. Now, all right. So in terms of the anatomical structure, so you're supposed to know the how far the implant should be placed from the sinus. Okay, how far anterior it should be placed from the mental foramen. So from the IN, so the IN is here. So if you're going to put an implant, okay, supposed to be 2 millimeters from the IN, okay, from the superior uh, cortex of the IN canal. Now, the IN, when it exits the mental foramen here, sometimes it loops around like superior anterior, okay, before it exits. So the recommendation is to place the implant at least 5 5 millimeters anterior to the, okay, so this space here supposed to be at least 5 millimeters anterior to mental foramen. Okay, so make sure you remember that. All right, so the next one is review series number 5. Okay, make sure you subscribe so you can receive notification for the next series. Okay, again, if you have any questions, comment or email me.